So, a very good morning, doctors. On behalf of Dr. Reddy Laboratories, I, Sai Kumar, would like to invite all of you today's peer exchange forum on heart failure. So, mainly this forum discusses about GDMT mediated HF therapy as well as various aspects of HFrEF as well as HFpEF. And today we have most eminent personalities of Kolhapur as well as Maharashtra. And Dr. Chandrasekhar Vasantrao Patil is having with us as moderator for today's forum. So he is one of the most eminent cardiologists in Kolhapur, having more than 20 years of experience. Currently head of cardiology department, Sai Cardiac Center, Kolhapur. We are very much delighted to have you, doctor. Thank you, sir. Thank you for accepting our invitation and coming here. And we have Dr. Sachin Patil, head of Sachin Super Specialty Hospital, who is having more than 20 years of experience. And Dr. Abhijit Shelki, DNB Cardiology, head of Cardiology Department, Krishna Medical College, having more than 20 years of experience. And Dr. Riaz Umar, who is one of the most renowned cardiologists with more than 15 years of experience. And Dr. Rohit Dikshit, head of Dikshit Heart Care with more than 10 years of experience, and Dr. Vijay Sinha Patil with more than 10 years of experience. So we are very much delighted to have you all in today's peer exchange forum, doctor. So handovering the session to Dr. C.V. Patil sir to take the session forward. Thank you, sir.
Discussing about heart failure. When I talk about heart failure, I remember in 1991 when I was a first year resident. That time the only options available for any heart failure patients were digoxin and Lasix. In 1991, the first trial of heart failure with enalapril was published, and thereafter the era of modern therapy of heart failure started. Now in 2023, there is not a dearth of knowledge, but it is an excess of knowledge that is a problem. So in order to circumvent this information flooding, we have to have some kind of a pragmatic approach. And I'm having all the dignitaries or distinguished cardiologists from our Western Maharashtra, and we'll be discussing some of the pragmatic approaches in heart failure. Now just to quote the present problem, in 2018, 5 years back, in NEGM, one heart failure registry was published. It was CHAMP Heart Failure Registry, which was published in 2018, and it included more than 3,000 patients. And the topic of discussion was what is the current scenario in day-to-day practice in general cardiology practice. So in that study, it was found that amongst more than 3,000 patients, only 30% of the patients were receiving one of the treatment modality with target dose. And they found that only 1% of the patients were receiving all the treatment modality which has been advised by guidelines in proper targeted dosages. So to fill this gap, we'll be having some pragmatic approach. We'll not be discussing much about guidelines, recommendations, and trials, but we'll be discussing our day-to-day practice because all of us are experienced enough so that we can make our personal opinions. And I will start with Dr. Rohit Dikshit, and he will be talking about heart failure classification. Now, once we diagnose any patient with a heart failure, the baseline investigations like blood chemistry and along with routine chest X-ray, ECG we do. And then the first investigation will be echocardiography. So what are the points which you will want to discuss regarding heart failure classification?
Yeah, actually, once we are dealing with the heart failure patient, we usually try to classify that patient according to the ejection fraction. So since 2020 universal definition of classification of heart failure, we are recently classifying those patients according to ejection fraction. If the patient's ejection fraction is less than or equal to 40%, then we classify them as heart failure with reduced ejection fraction. If the patient's ejection fraction is between 41 to 49%, then we classify them as heart failure with mildly reduced ejection fraction. And if the patient's ejection fraction is more than 50%, more than or equal to 50%, then we classify them as heart failure with preserved ejection fraction. And those patients who are improving with the GDMT and the HF ref patient, those patients who are improving with treatment
Thank you, Dr. C.V. Patil, sir, and it's indeed good to talk always about this deadly condition, that is heart failure, which obviously has a mortality equivalent to many cancers. And now going forward, now over the last 2 decades, we have seen almost a sea of change the way we treat the heart failure. And now we have these beautiful fantastic four pillars of heart failure management. And when we talk about heart failure management, that we are talking about HFrEF, that is heart failure with reduced ejection fraction. So these four pillars are nothing but those traditional evidence-based beta blockers, mineralocorticoid receptor antagonists, the RAS blockers, which are nothing but AC inhibitors, angiotensin receptor blocker, and ARNI. And lastly, the new in town, that is SGLT2 inhibitor, namely dapagliflozin, and also the newer drugs. So why these four have been chosen as a four pillar is their ability, which were shown in their everybody's randomized control trial, that these are the drugs which are known to cause reduction in the mortality as well as reduction into the number of heart failure hospitalization. These drugs have also shown to reduce the signs and symptoms when interrogated on those various questionnaires in these trials. So these four drugs are forming the pillar of management of our heart failure with reduced ejection fraction. Now, mortality is very important when it comes to country like India, because the socio-economic impact of this therapy is also important. The recurrent hospitalization add to the new burdens into the cost factor of the heart failure management. Now, these drugs can be added sequentially at a low dosages, and rapidly these can be up titrated, and there are various guideline based recommendation, especially for the first three molecules, that is ARNI, beta blockers, and a mineralocorticoid receptor antagonist. The fourth one is actually the very easiest one, which doesn't require any dosage up titration, that is dapagliflozin. We have only one dose, and the ease of use is very, very easy. So I think these four drugs should form the pillar of management. And of course, we have many more drugs which can be used depending on the various compelling indications. So I think we will subsequently study about these drugs and then how to add it. Giving all these drugs together, there is no guideline at present. It is given to the discretion of the physician, and it is more of an art of practicing rather than art of science. We can add all these drugs at a low dose, given that the patient is ability to tolerate their side effects.
So in your practice, suppose if the patient is you only.
I think.
In your practice, so which drug you start as a first line treatment?
Yeah. So whenever patient of heart failure decompensates and he comes to the critical care unit, obviously we start with diuretic, these drugs which are generally the loop diuretics. They have not shown to add any mortality benefit, but definitely they will reduce the symptoms. And whenever we are achieving euvolemia, I think the first drug to start easily will be the ARNI, which is nowadays coming up very strongly with its benefit over and above the AC inhibitors and ARB. Secondly, we have a limitation of congestion, so that our beta blockers should actually be given little late. Once the patient becomes congestion free, we can add beta blockers. Thirdly, one drug which can be easily started even with the subnormal or borderline pressures will be the SGLT2 inhibitor, such as dapagliflozin. The dose is 10 milligram as given by the trials. The patients who actually have a ejection fraction less than 35%, the drug, this case comes to stronger in favor of mineralocorticoid receptor antagonists such as spironolactone or eplerenone as given in the trials. So a patient gets a diuretic in the beginning. Once the patient becomes euvolemic, the other three drugs are to be started, and probably when the loop diuretics is to be down titrated, one can easily add the spironolactone and pass on the benefit of these drugs. Of course, how they tolerate it is based on various other factors which a physician has to see. The renal function also makes a very important assessment. A physician has to see how the potassium is behaving, the creatinine. In generally, we actually repeat these labs every second week, provided we want to aggressively up titrate these molecules. Earlier, the guidelines said that we have to wait for 4 weeks for up titration. But nowadays, they are also allowing to up titrate as early as 2 weeks. Mind you, other drugs other than DAPA and mineralocorticoid blockers, these drugs have to be slowly up titrated, carefully watching the patient's blood pressure, as you rightly said, the volumic status and the renal function. So,
Regarding SGLT inhibitors, what is your personal experience? How many percentage of the patients they do have a recurrent urinary tract infection that you have to stop that drug altogether?
yeah, it's a very, very important question. Blindly starting this molecule obviously will have its own side effects. These patients will have to be educated about importance of genital hygiene. If they can already having diabetes especially, then this is more important. They should be advised about proper maintenance of the hydration, then recurrent maintenance of the genital hygiene, etc. Should they develop any genitourinary tract infection, temporarily stopping this drug and reintroducing them after a gap of maybe 2 weeks, that also can serve the same purpose. But in our practice, we have seen up to 5 to 10% of the patients, they do develop GUT infections and then making a case for their temporary withdrawal. But most of these patients, when they are explained properly, they do tolerate these medicines.
In one of the, just a comment regarding up titration of Ernie's, there was one small study of acute decompensated heart failure, and they studied two different ways of up titrating the dosages. The first way was doing it in a condensed way, like to start with 100 milligram twice a day and go to 200 milligram twice a day within 2 to 3 weeks. This was a condensed arm, and the second arm was a slow arm. It was a conservative arm where 50 milligram twice a day was given for 2 weeks. 100 milligram twice a day was given for 3 weeks, and thereafter, after 5 weeks, if the patient was tolerating the dosages, it was increased to 200 milligram twice a day. And at the end of 3 months, they found that in the patients where the titration was done fast, they had a problem. So the percentage of the patients who were reaching the target dose was significantly lesser. So you have to be conservative in practice. So going to a further question, like suppose if the patient is already receiving 4 drugs, so will you be interested in starting a second line of treatment, or you will be satisfied with the 4 pillars?
Now, there are some second line drugs, as you said, the drugs like ivabradine, the digoxin, hydrolyzine along with nitrates, and then newly introduced vericiguat and omecaptive mecarbil. These drugs have their unique advantages over the other. But discussing about a few, that is ivabradine, we have noted when beta blockers alone are not able to control the heart rate to the target of below maybe let us say 70, or in spite of optimal dose of beta blockers, the heart rate continues to remain higher, then this becomes a very strong case to add a drug like ivabradine, and it has also shown some mortality benefit in trials. So I would use ivabradine only if optimal dose of beta blocker doesn't give the heart rate control. Secondly, if the patient continues to be in atrial fibrillation despite maximally tolerated beta blocker, we can also add digoxin, although this may not add to any mortality benefit. Thirdly, if these patients are still remaining symptomatic in spite of optimally treatment, then probably a fifth and important pillar which may be upcomingly seen in the later guidelines is vericiguat, and it's a newer drug which actually have shown equivalent benefits when it comes to reduction of hospitalization due to heart failure. So that drug is also increasingly being used. We have used maybe dozens of patients, and they have not shown any major side effect profile. They are usually well tolerated. So probably that class of drug I would use even after using these 4 pillars optimally. Lastly, the other drugs like hydrolyzine, and I think those are reserved for those patients who have a subnormal renal function or declining EGFR.
Now, in bronchospastic airway diseases, we consider beta blockers are contraindicated. In your practice, what proportion of COPD patients they do tolerate beta blockers?
These drugs such as bisoprolol and extended release metoprolol and carvedilol, they do have some bronchospastic increase in the bronchospasms. We generally decrease their dose temporarily. However, if the bronchospasm worsens we might have to lower these or may even take them off treatment. Around 5 to 10% of patients, they are very, very severe COPD patients, probably requiring temporary stoppage of these drugs. I think the same question I will pass on to the other panel also.
Among
Any
the
comments?
beta blockers, my experience in Indian population says that metoprolol is a better choice because of that. It is most of your heart failure patients have a low blood pressure. So metoprolol has a very weak antihypertensive action. Second thing, metoprolol is very well tolerated in the bronchospasm patient. And again, when it comes to up titration of the dose, compared to other beta blockers, second choice may be a carvedilol and third may be bisoprolol. These have a very good antihypertensive power. So metoprolol we can go up to 100 BD in Indian population, which is the target dose. So in my experience, most of the patients, even if having a known case of allergic asthma or COPD, they tolerate beta blockers better. Only few patients, like one patient needs admission. He is a doctor. After starting beta blocker, he is an old case, known case of allergic bronchitis, and he needs admission, almost ventilation, non-anesthesia. But otherwise, most of the patient tolerate well.
Sachin, you want?
Yeah, maybe I divide all these airway diseases into three parts. One is a proven childhood asthma or a allergic airway disease, then emphysema and a chronic bronchitis. So collectively we call it as COPD. So all these COPDs are inflammatory disorders, and in fact they do well on beta blockers. The commonest cause of mortality in a COPD patient is a cardiovascular rather than their infections cause.
Especially smokers.
So yes, especially smokers. So we should make all right attempts to put them on a beta blockers. Now amongst the thing, if we go to the pharmacodynamics, the highest beta 1 selectivity is for the nebivolol, followed by bisoprolol, and then others. So generally my experience is they tolerate very good as far as bisoprolol and nebivolol is concerned, because they are very selective. If coming back to the carvedilol, which is non-selective, alpha as well as beta, so there I feel inhibited, followed by then the metoprolol and others. So we should, and personally there have been many proven patients where we have started and they tolerate very well, except childhood asthma or allergic airway disease. So I won't be surprised that after a few years there might be a guideline that all COPD patients should be on beta blockers because of mortality benefit.
Rather than preventing them.
Yes.
So the two comments, one comment is that the beta blockers can be divided into vasodilatory beta blockers and non-vasodilatory. So if somebody is having a borderline hemodynamics, as you were saying, that metoprolol is a better choice because it's a non-vasodilatory beta blocker. And there are other two drugs which are recommended in heart failure, carvedilol and bisoprolol, both are vasodilatory. So probably in borderline hemodynamics where the pressure is around 100, 110, probably they should be avoided. Regarding nebivolol, there is a slightly lower class of recommendation because it was only an elderly patient that was studied. And the second comment is regarding MRAs. When the first trial of MRAs was published, that was a RELS trial regarding spironolactone. At that time, there was one publication from Canada, and it was, they're having a national statistics on mortality and cause of the mortality. And they conclusively proved that at the publication of the trial, the death rates because of hyperkalemia, they almost 10 times increased in whole Canadian population. So if it is a unmonitored addition of MRAs, then we have to be slightly cautious. We have to do repetitively potassium levels, especially in patients who are having renally challenged patients. So these are the patients where we have to do repeated biochemistry profile. You want to add something?
Regarding my choice of beta blocker, most of the times I start bisoprolol, or suppose if patient is on a metoprolol and he develops spasm, I switch over to the bisoprolol, and they quite tolerate the bisoprolol. Probably up to 2.5, 5, probably more than 5 milligram, they don't tolerate. Again, they may go into the spasm. And regarding digoxin, whenever there is a RV dysfunction, I choose digoxin as a drug, because most of the times right heart failure is very difficult to manage. And my personal experience with digoxin in this patient is good. At least they will have clinical improvement, symptomatic benefit, although it doesn't add to the mortality benefit. But digoxin works very well in RV dysfunction.
Just one question to you regarding digoxin. Whatever the literature says, consensus document says, that the digoxin should be given to any patient, then we have to have a serum digoxin levels, which we hardly do in clinical practice. So what is your preferred dosages in an adult patient who is weighing more than 60 kg of weight, renal function is normal, then what dose you advise?
So I don't go for rapid digitalization.
Right.
I go with the regular dose 0.25 milligram once a daily, and whatever conventional, it is not into guidelines, but Saturday, Sunday off day, and then I continue with the same dose. Very few patient comes with the digoxin toxicity, especially if there is a hypokalemia or if they develop renal dysfunction over a period. So we have to monitor potassium and renal functions, and obviously we have to see the clinical response. Suppose if the patient is getting clinical response with the digoxin without other problems, that should be a sufficient clinical evidence that the dose is working for that patient.
There is one post-hoc analysis of digoxin heart failure trial was that the serum levels of digoxin were related to long-term mortality. So because of that, it may not be a scientifically correct, but I give always a 0.125 milligram maintenance dose rather than making the patient off on Saturday, Sundays. It might not be correct way. The correct way is to do serum digoxin level every 3 or 6 monthly, but this is an individual choice. Any comments?
One right heart failure sir told. I want to share one experience and ask your experience also, because we don't have a lot of data and lot of medication on the right heart failure. So few patients of me which are very well improved on ARNI, because we know that heart failure is a now neurohormonal syndrome. It is not a right, left or everything. So it is a neurohormonal syndrome. The patient came with anasarca, admitted for almost 21 days, put on the diuretics, weight reduction is from 89 kg to 72 kg, and he is very well now doing an ARNI, and the requirement for diuretics not less than 5 milligram half better. So what is your experience using ARNI in right heart failure, sir? That patient is COPD, right heart failure, anasarca, and known case of diabetes, hypertension, mild coronary disease. So what is your experience about right heart failure and ARNI?
So whenever we are talking about right heart failure, there is hardly any data in the literature. So whatever is applicable to left heart should be applicable to right heart, because we know that the interventricular septum, which constitutes 40% of the LV mass, it is a common to both ventricles. So whatever is applicable to left heart should be applicable to right heart. So once that patient is euvolemic, then only we have to start ARNI, because right heart patients are very notorious to go into cardiorenal syndrome. So we have to make them euvolemic, and once that has been done, we can definitely start ARNI, and should be started.
Yeah, agreed. Most of the time it is a combination of both.
Now coming to
ARNI.
anasarca, and we are discussing anasarca. Probably Dr. Sachin Patil will enlighten us regarding the acute decompensated heart failure, the role of diuretics in that.
Yeah, acute decompensated heart failure is basically a syndrome. Because of so many etiologies, we can have an acute decompensated heart failure. The commonest thing is a fluid overload and a symptoms of heart failure or a congestion, and that's why the diuretics rose a very pivotal role in that decompensation, because patient is interested in symptomatic relief. Let me feel better. So there we give the diuretics. In that now loop diuretics are the choice of drugs. So commonly we use is a furosemide, but even I use quite a bit torsemide also. Little bit I will stress upon the torsemide is because of more pharmacokinetically predictable action, longer duration of action, and a more consistent results, where the renal concentration achieved is much better. So that's why torsemide sometimes I prefer. Or sometimes we come across the phenomena called as diuretic resistance, because of the improperly given diuretic doses. That is, let's say a Lasix given at a two doses only apart. So in between period when the concentration is low, the patient tubules absorbs practically everything, and that's why patient lands up into the diuretic resistance. Or borderline renal failure patients, they doesn't achieve the sufficient tubular concentration to give the results, and that's why they are called as low ceiling diuretics. So that's why sometimes this leads to the false diuretic resistance. So there again this thing works. And very rarely, suppose if there is a renal failure also and there is a gross fluid overload, so there I use metolazone also, but that is only strictly for the shorter duration. Because if we give metolazone 1 to 2 hours prior to our loop diuretic, it helps in increasing the tubular concentration and their oxygen is very augmented and we get a good diuresis. So in acute decompensated, maybe first 24 to 48 hours we can use all these things. See, our aim is to achieve the good symptomatic relief early in the part, relieve the congestion, relieve the symptoms. Moment they are euvolemic, they should be back to these four pillars. And in sequence or simultaneously, we can add as per the patient profile. So the moment his blood pressure and renal and potassium allows, I put them on the ARNI as soon as possible. If his blood pressure is fine and his heart rate is okay, is not much of bronchospasm, then beta blockers are on. I like SGLT2 very much because again a low dose diuretic action, natriuretic action, as well as there is no need to up titrate. The only thing which I see is whether the patient is taking orally or not. If he is taking orally, there is no gross contraindication, GFR more than 20, I put them on SGLT2 because no hemodynamic effects, no chronotropic effects, except thing we have to is acute renal deterioration we should avoid, or euvolemic ketosis or euglycemic ketosis, which can be watched for. Otherwise, SGLT2 also initial helps by a slight diuretic action also. And another thing is we say about when to add MRA. Somehow I would like to differ from the Western population and our population is our population tolerates MRA is much better. The incidences of hyperkalemia are much lesser as compared to the Western literature reported population. So that's why within 24 to 48 hours, we put them on, commonly aldactone or something, and they do tolerate very well. Except few patients who develop side effects on that, generally they come on follow-up with the gynecomastia and all. Just those population we put them on the eplerenone. Otherwise, MRA works good for most of the things. So for me, diuretics only in acute decompensated till we achieve decongestion, symptom relief and euvolemia. As the follow-up starts, I started tapering down and give the place for ARNI or a beta blocker, which are much better drugs which saves life.
So in conclusion, ARNI is a kind of diuretic sparing agent, and once we are reducing the dose of, we are adding ARNI and we are reducing the dose. One thing I wanted to add, is there any role of acetazolamide in an acutely decompensated heart failure? Do you use any time?
No, means particularly I have not used it.
There are recent there are very few trials of diuretics in heart failure, even though we all agree that even if it is not been mentioned as a 4 pillars, without diuretics we cannot treat heart failure because any pulmonary edema and if we start 4 pillars, they will not survive. So acetazolamide has having a significant role, especially in patients who are having diuretic resistance, not coming out of IV continuous infusion of diuretics. So these are the patients where we should give 500 milligram of ideally IV acetazolamide, which is not available with us. So we have to give a oral dose, and for 3 days it is sufficient. Only thing is that adding metalazone, it leads to significant hyponatremia, hypokalemia, and we have to be aware of that. One more question I wanted to ask before Riaz's comment is that you prefer furosemide or torsemide on OPD patients?
I generally big fan follower of torsemide because it gives me a more predictable action, a longer duration of action, and the dose to dose variability is lesser because of the higher protein binding.
Yes.
So I prefer torsemide.
And second thing is that it is having a significant bioavailability.
Yeah.
So suppose if you are giving torsemide 20 milligram, it will be 90% absorbed. Whereas if it is a furosemide, only 50% bioavailability, especially patients who are having a low output, low duodenal flow, who are having gut edema. So these are the patients, they will become easily diuretic resistant. And second thing is that the hypokalemia incidence is significantly less with torsemide. So chances of sudden cardiac death will be prevented by unmonitored treatment. Please ask.
Second thing, use of diuretics after discharge. One need to taught for all our physicians, general practitioners also, and to patient also to monitor how to monitor their weight and edema. Because what happens when we add the need of the diuretics significantly reduces, and keeping the same dose of diuretics, most of the time what happens, the patient don't follow with us. Okay, so the need of the diuretic significantly decreases after adding the ARNI. So patient has to be taught to monitor his edema and weight. And whenever there is a increase in the weight, they can take one extra dose of the diuretics to avoid the acute admissions. And diuretic required may be nil after adding the ARNI and the dapagliflozin. So this concept is not well known still many our populations, so that you have to be
Going one step ahead, I always advocate all patients of heart failure to buy an electronic weighing
Yes,
machine
morning.
and to weigh them at particular time of day. For example, if it is 7 a.m., it is convenient to them, or maybe 9 p.m. But the same day, same weight, there should be a weight variation of plus minus half kg to 1 kg.
Yes.
If they are accumulating more than 1 kg, the chances that getting admitted with heart failure will be significantly more. If they are reducing weight by more than 1 kg, the chances of hypoperfusion in the form of giddiness, syncope will be significantly increased.
So, best time to take the measurement according to my experience is the patient coming up early morning after coming up from the bathroom, because that time that is the basic.
Many patients they are accustomed to drink water, so it has to be a timing of the particular
Yes.
timing, so that they can monitor according to their schedule at the same time. So this point also is well taken.
Yeah.
It should be after
Generally
coming
morning,
from washroom.
dry
Yes,
weight,
yes,
but
dry.
yes, customization is.
So coming to a next question regarding a cardiorenal syndrome, renal dysfunction patients, and the role of hernias. So what threshold you keep that? So above this threshold, we should not give hernia if there is a renal dysfunction. So what is a take about that?
Yeah, so first of all, I would like to say that creatinine is never a good marker for kidney function. It can be variable response. That's why generally I take out a point, because QX calculate is there in all the mobiles. Take a pen to calculate the GFR, and GFR will guide the therapy. So anything above 30 GFR, we can give ARNI safely. Now the question is, as per that tertile, we can divide above 60 and above GFR. There is no need for much of the dose adjustments also. We can safely prescribe ARNI as per our routine schedule and adjusticate them. If it is 30 to 60, generally I start with a much lower dose, maybe 50, or even blood pressure borderline, then 25, and then every 2 weeks we can go. So if those moderate renal failure patient, if they increase the creatinine from their baseline more than 30%, that is a time I hold on or reduce the dose and check for some time, is it increasing more? If it is more than 50% rise, then I stop the ARNI, because probably his kidney is too much down and he is not fit. That creatinine.
In these patients, do you restart it after some time, or you change over to something like isosorboid dinitrate hydrolyzine combination? If there is a one episode of having a renal dysfunction where the creatinine has risen by more than 1.5 times, or maybe urine output has reduced maybe 0.5 ml per kg per hour. So do you restart them on the same drug, ARNI, or you change over to another class?
Yeah, I think ARNI is too good class of drug to be denied, and that's why generally I take a point ki, okay, if I had to stop, okay, then note down ki what is the cause of renal deterioration. Is it fluids are low? Is he on over diuretics? Is there anything UTI which is going on because of SGLT2? Why he is into that renal failure? Why that deterioration happened? So identify the cause and correct it. Once it is corrected after 1 or 2 weeks, then I always make an attempt. Even for the hypotension, I do same thing. I at least make 2 to 3 attempts to put them on the drug. If not successful, let's say every time I get into encounter failure, then I document on the paper that ARNI is simply intolerant to the ARNI because of renal deterioration or because of this. So another important cause which I have found is substantial patient, they turned out to have renal vascular disease also, because they are coronary artery disease also. So I make a time to get a USG KUB done and a renal Doppler, and this has to be ruled out very carefully, and other renal deterioration causes.
So because there is an overlap of cardiac pathology and renal pathology, because many of these patients will be hypertensive for long time, diabetic for long time, so they will be having a concomitant renal failure as well, cardiac failure. So I make a point that somebody's creatinine is significantly impaired. Suppose if it is more than 2 and patient is having a heart failure, I always involve nephrologist in the management. So it becomes easier whenever they get a renal decompensation. Now coming to...
No, but just a small comment I would like to make. Ki if we see the sub-analysis of many of the trials, if we see now we have so many Paragon, Paraglide and everything, the ARNIs have shown to reduce the 3-point MACE for the renal also. Means deterioration of the GFR, progression to the end-stage renal disease, or the renal outcomes are uniformly reduced to the risk of almost 50%. That they have been saved. That's why if we have to mild to moderate renal failure, and we don't want them to go into the ESRD, or we don't want them to go on the dialysis, they should be on ARNI.
Definitely, that is a point, but many a times we miss some of the renal pathologies
Yes.
coexistent, and many of the patient, if they require a renal deterioration, and if you are calling the nephrologist for dialysis, rather than having a proper consultation with them will be a better idea.
Absolutely.
So that was the reason.
Just one remark, sir, regarding nephrologist. Many times I have seen they add soda backup supplements and they
Supplement. And that is- that is it.
sometimes
But these are very small supplements. Suppose if it is a soda bicarb, then it comes to around, we have measured it recently, like any patient of hyponatremia, if you are putting them on a sodium, how to quantify that? So what we do is that to remove take a B complex capsule, remove the drug from it and put a salt in that. So it will be kind of a structured sodium giving. So it comes to around 500 milligram for a single capsule. If you are giving 3 capsules per day, it comes to around 1.5 milligram. So it is a 1.5 milligram is too less a dose. The recommendation is to the moderation should be up to 5 milligrams. So soda.
how frequently you have seen that
No.
the nephrologist has started the medicine and you are all therapies.
Right. No, they are very reluctant to give actually ARNIs. We cardiologists, for a creatinine of 2 to 2.5, we are more enthusiastic about cardiac failure, but they are usually reluctant to give ARNIs in this kind of substance.
Even diuretic dose also they try to.
Yes.
Yes, sir. You talk about the one drug, isosorbitol plus hydrolazine. Two important things I want to stress about that. One population which is having a raised creatinine, like Western population, Indian population very well tolerate that drug, and that to be added to the all patients who we cannot give the ARNI, who's on raised creatinine, they have some fantastic benefit. And second thing, sometimes ARNI is intolerated because of cough. In some patient have too much cough, so the giving a valsartan in spot of ARNI and then adding a isosorbitol combination, hydrogen oil. This drug is less utilized, so it is to be used in extensive way in patient in these two populations.
But one
So
thing,
one-
sir, regarding, sorry, I just wanted to add, if the EGFR is further declining on ARNI, we can actually withhold temporarily and add a SGLT2 inhibitor.
Right.
I think that is allowed up to a EGFR of 20.
20.
Yes,
And
yes.
that can be important
No, but
substitute.
even SGLT2s are known to cause acute drop. So if
Yes.
it is deteriorating
They actually
because of
cause
one
5
thing,
ml EGFR
Yes.
deterioration, but they have not
Unless-
shown
But
to
over the period of time, they
actually
improve. Actually, the rate of
Help.
deterioration is significantly reduced. Coming to a next point, a role of ARNI in severe mitral regurgitation patients.
yeah, again in severe mitral regurgitation, we need to make an attempt to identify as to what is the cause of this mitral regurgitation. Means, is it a rheumatic valvular heart disease, or is it something correctable like a caudal rupture or a tendon rupture, or is it because of the simply a dilated LV, dilated annulus, and that resulting into the central MR. In fact, we have quite a good of data that if it is a MR because of the LV dysfunction, that is we say functional MR, even if it is moderate to severe, they do very well on the ARNI because of the positive remodeling and down the line structural remodeling, the LV indices comes down and the MR comes down significantly. So as far as the heart failure resulting into the MR, excellent choice and good results. If it is a primary MR, let's say a rheumatic valvular or something, in that case still ARNI helps as per me, because the choice of drugs are the vasodilators. We have to reduce the pressure on the arterial side so that LV finds it easy to empty on this side rather than the regurgitation. So we were giving enalapril and all day and day out. So again ARNI comes into picture. Sometimes very difficult to operate a patient of severe MR and severe L dysfunction, and they have one of the very high mortality. So to support that LV till some time, come back to the shape, come back to the reduction of heart failure, again ARNI helps. But whenever there is a MR, we must try to find out, is that MR treatable by some cause or some mechanism like caudal rupture, MVP, CRHD, where we can treat that MR also. But I have seen that many of these ARNI have delayed the mitra clips. Obviously we don't do, and for us it is astronomical high of 25 to 30 lakhs. But it can delay it, and there are now results also or reports also.
When we talk about a severe mitral regurgitation, it is our common representation. Like suppose if we see 100 patients of mitral regurgitation, maybe 5 or 10% of the patients will be having severe MR, which we will be discussing. but the patients who are moderate MR, 2 by 4 MR or maybe 2 plus by 4 MR. So these are the patients who decide the prognosis, especially if these patients are undergoing CABG. I have seen that patients who are having only moderate MR, the chances of coming out of CABG is significantly reduced as compared to the patients without MR. So these patients we have to take very rationally with addition of a proper guideline management even before sending them for surgical revascularization. Now we have talked sufficiently about reduced ejection fraction. It is a time to go for a discussion on a preserved ejection fraction. We all know that 50% of the heart failure patients are PEF heart failure. Dr. Riaz, can you have some comments on that?
Now coming to the heart failure with preserved ejection fraction, by definition we know that the LV function should be more than 50%. Patients should be symptomatic. We know that the 5-year mortality for heart failure with preserved ejection fraction is almost 50%, which is similar to the mortality of heart failure with reduced ejection fraction. And most of these pathophysiology of this heart failure with preserved ejection fraction is not well understood. We don't have a proper guideline-directed treatment for this kind of population. So early detection of this patient with heart failure with preserved ejection fraction by clinical examination in the form of RED-GVP or ANA-SARCA, then doing biomarkers like BNP level, and we have a very good choice of tool available with us like echocardiography. From E by E prime, if more than 15, we can diagnose this patient of population. And these most of the patient, the pathophysiology behave differently, and the mortality is almost 50% at the end of 5 years. So we have to detect this patient at earlier stage, and most of these patients are associated with either diabetes, obesity, coronary artery disease, elderly population, or atrial fibrillation. We have to treat the associated comorbidities in this patient. Among the drugs, you can talk SGLT2 has shown benefit in 29% reduction. Most of the find reduce hospitalization, not much of mortality benefit. And other drugs like ARNI, beta blockers, and spironolactone, they have already shown the benefit, but not in the population with preservation. Again, importance, it is not only the LV function, it is a NYHA class of the patient. Those patients who are having a NYHA function class 4 and those patients who are in the NYHA function class 2. So history regarding the NYHA function class is very important because that decides the short-term and long-term mortality in this population.
In this kind of a population, preserved ejection fraction, is there role of ARNI in this kind of a population?
Yes, sir. Because what benefit we get in the heart failure reduction fraction, that benefit may not be there, but reduced hospitalization is seen in this population. So ARNI should be definitely started, though it is presently class 2B indication, but ARNI should be given. Again, aldactone, because most of these patients are obese, hypertension, and whenever it comes to drug of choice, aldactone is spironolactone is previously well studied for the population of the hypertension, the population of the resistant hypertension. So whenever patient, these two drugs should be added in this population unless contraindicated.
So there are two subsets of patients with a preserved ejection fraction which will be benefited. Even though the Paragon heart trial was not showing a significant benefit, there were the statistical significance was very borderline. Suppose if it is a 0.05, we consider this as a significant reduction. But if it is 0.059, then we consider it statistically insignificant. It is something like 99, somebody got out, and 100, then he has make a century. So it is something like that. So it is not that they are not useful, but that not significantly useful. The second thing is that the patients who are having a borderline ejection fraction, meaning the ejection fraction above 40% but less than 57%. So these are the mid-range ejection fraction patients, as well the lower part of the preserved ejection fraction, they will be benefiting significantly. And subgroup analysis, females were significantly benefited. So these are the two subsets where we will be starting these drugs. And apart from that, good control of hypertension. Going almost to the sprint level criteria, like going below 120 will be significantly useful because it is not a particular illness, but it is a systemic inflammatory disorder where comorbidities, they will add to the significant heart failure. So we don't have a proper armamentarium so that we can reduce the comorbidities by reducing weight, asking them to have a good exercise, and medically or pharmacologically, we can control their blood pressure to optimum level. The next question is regarding the improved ejection fraction. Somebody had a LV dysfunction, 35%, has gone up to 45%. No reversible factors like no peripartum cardiomyopathy, no myocarditis. Patient had a LV ejection fraction of 35 gone to 45. So what is your take on that?
Yeah, so those patients who are the improved ejection fraction, the guideline directed medical therapy should be continued because already we have data available. If you reduce the drugs or we withdraw the drug, most of the patients land into the again symptomatic heart failure within 6 months. I will discuss how to diagnose the relapse in this population. Echocardiographically, if LV ejection fraction decrease by 10% or left ventricular end diastolic volume increase more than 10%, or there is a BNP level increase more than twofold or more than 400 nanogram, and again most important is symptoms. These are the four criteria which can detect the relapse in this population. But guideline directed medical treatment should be continued. Even I advise if patient can afford to get a BNP level done, we have to get a BNP level done, and if it is still high, we can have to up titrate the medication rather than the reducing medication. Our Indian population is always asked, sir, now I improved, my ejection fraction is improved, why not to reduce the medication? But we have a lot of data available. Continuing medication has a mortality and morbidity benefit, and the reducing medicine causes the relapse. Again, we have to start from the bottom, so we have to continue medication in that population.
Now, coming to last part of our discussion, Dr. Abhijit is a electrophysiologist. He is having a significant expertise, and he will enlighten us on the device therapy related to heart failure. It includes something like ICD and CRT as well. There will be patients who will be having complete heart block, whose ejection fraction will be in the lower range between 35 to 50%. So, you please make comment regarding that.
So whenever we are discussing about the device therapy in heart failure, there are two categories of devices. One is cardiac physiological pacing, where we try to improve cardiac output, and other is a AICD group, where we try to prevent the sudden cardiac death. So coming to the first category of devices, cardiac physiological pacing, which comprises cardiac resynchronization therapy, where we pace left ventricle either through the transvenous system or from the epicardial surface. In layman language, we call this as a triple chamber pacemaker. And second newer category is conduction system pacing, where his bundle pacing, either selective, non-selective, or left bundle pacing. Of late, left bundle pacing is more popular than the his bundle pacing because of the problems with the his bundle pacing. But as of now, we have almost 20 years data on the cardiac resynchronization therapy, where it improves the morbidity, it improves the symptom profile, it improves the mortality. Most of the patients who were listed for the transplant are delisted because of this therapy. But there is a subset of population who gets response to this therapy. So what are these patients? One is they should have symptomatic heart failure despite guideline-directed medical therapy, what we discussed. After optimization of this therapy for 3 months, still they are symptomatic. If their ECG is showing left bundle branch block, if their ejection fraction is 35% or less, this population get benefit of this CRT. Obviously, not all patient gets benefit. There are some non-respondents also, depending upon the other factors like scarring, RV dysfunction, other factors during the implantation. But we have seen such patients getting benefit out of this therapy. Now, coming to the conduction system pacing, left bundle pacing, still it is not an alternative to the cardiac resynchronization therapy. As of now, we can use this as an add-on to the left bundle pacing, or left ventricle lead in the CRT. Suppose if I do a CRT and if I get a suboptimal result of a LV lead, then I can add a left bundle lead or his bundle lead to just support that left ventricle pacing. But still it is not into guidelines. There is an encouraging data for last 2 years and observational studies, but still it is not into the guidelines. Now, coming to the AICD, these therapies are offered to the patient who develop ventricular tachycardia as a secondary prophylaxis to sudden cardiac death, or a primary prophylaxis to the patient subset who are at high risk of sudden cardiac death. So what are these subsets? The patients who actually have ejection fraction less than 35% and NYHA class 2 to 3 symptoms. We generally don't include class 4 symptoms because majority of cause of death in this patient is a pump failure, not a arrhythmic death. Studies have shown that the arrhythmic death is common in patients with a class 2 and class 3 patients. So non-ischemic as well as ischemic group with the NYHA class 2 or 3 symptoms with ejection fraction less than 35% are qualified for primary prophylaxis. Now, if NYHA class 1 symptoms with ejection fraction less than 30% with ischemic heart disease, they are also qualified for the primary prevention. The biggest pitfall in this guideline is ejection fraction. We know that it is variable. There are a lot of imaging error, calculation errors. And despite these guidelines, we are not going to, patients are not going to get benefit out of that. All patients are not going to get benefit. But these are the guidelines. There are controversy in practice. If you ask me, many people still don't practice primary prophylaxis heavily. They still doubt about that because we have to see cost effectiveness, which is probably in Indian population is difficult. To offer all patients is difficult.
Just to have a brief outline regarding those are the patients who will require a heart transplantation, even though it is more of a theoretical question because maybe 0.1% of our heart failure patients will opt to LVAD or heart failure, but at least all the physicians should be knowing that what are the indications of heart transplant and LVAD.
So whenever patient is in stage D, refractory heart failure, now there are some parameters to categorize stage D refractory heart failure, like patients requiring inotropic support, patients getting a recurrent shock on the AICD, patients with NYHA 3B or class 4 symptoms, or patients having end-stage organ disease, or patients not tolerating the drugs or symptomatic despite these drugs. There is the option of LVAD or heart transplant. Now, such patients require mechanical cardiac support, especially when they develop shock. Now, we can offer them as a bridge to the recovery therapy. Few of the patients, after giving the support, may recover from that stage, and probably they may go to the stage or class 2 symptoms. Few of the patients wait till the bridge to the transplant therapy. So, as a cardiologist, what we can do in an acute situation is we can put them on an inotrop, we can give a IABP, we can give a ECMO, we can give a Impella. Now, Impella is not that cost effective in our population or our patient subset, because it costs almost 30 to 40 lakhs. Then there is an option of tandem heart where we directly unload the ventricle from the LA and shift the blood to the femoral artery. So aim of this acute support is to unload the ventricle, either from the aorta, from the LV, or from the LA. But obviously cost is involved. And suppose if the patient is appropriate for the heart transplant, we can offer them a heart transplant. That also requires a lot of infrastructure and a structured program to run the heart failure program.
And along with the social support from family and friends.
Yes.
A significant support.
Yeah.
Now, coming to general and common questions which are asked from day-to-day practice, I will not ask it to somebody, you can randomly answer these questions. Regarding the salt intake in heart failure, anybody wants to comment?
So, coming to salt intake, there are no as such randomized trials on this. But there are observational studies that if the salt intake is restricted to 2 to 3 grams per day, the symptomatic benefit will be there. But there are no strict guidelines.
Actually, there is one recent trial which has been published, sodium heart failure trial, and they have restricted sodium in both the groups. Like one trial was the giving of a 2300 milligram or 100 milliequivalents of sodium. It comes to around 5 grams of salt. It comes to a teaspoon of salt. And the other was 65 millimoles. So it will be 2/3 of it. And they found that by restricting more sodium, there will not be any benefit. This is one thing. It is not been found that a very strict sodium restriction improves the outcomes in the heart failure patient. But there is some data which is observational data. There is a J-shaped curve for a sodium intake, and if it goes below 65 millimoles, less than 2/3 for a person, it is very difficult to calculate. It is not a practical thing. But if somebody is restricting the sodium to an extreme extent, something like a saltless food, the mortality increases. It is something like a J-shaped curve of a hypertension. So too low blood pressure is detrimental. Similarly, too low sodium intake also is detrimental. The next question is regarding exercise. Like heart failure patient, is there any role for exercise?
Same like sodium, I mean, I can say it improves the quality of life, but it doesn't extend the life. With the graded exercise and cardiac rehabilitation, the study has found that the physical capacity improves.
There is something concept known as a lifespan where we are talking about the trials, like the increase in 1 year lifespan of a particular patient. So whatever the structured exercise programs has been done in heart failure, they were for 6 weeks and 8 weeks, and it is very difficult to analyze regarding these kind of things. But there is something known as a health span, like the quality of life, how much the person is getting, that is definitely improved. Recently, I was reading one non-academic book, and there the proportion of patients who are having VO2 max to a better level will be having a better survival. So indirectly, we can, it is not exactly the LV function that will determine the VO2, but it will be the muscle's capacity to extract oxygen from the blood and improve its capacity or efficiency that will be improved. It will be at the mitochondrial level, it might be at a cellular level. But whenever somebody is exercising within their symptomatic range, like without getting unduly tired or unduly symptomatic, these patients will have definitely a better quality of life and probably maybe a better lifespan also. Then another question is a resistant hypertension. There is an off-label indication of sacubitril valsartan in Japan, which has been approved in Japan for resistant hypertension. Anybody using it for resistant hypertension?
Yes, sir. I am almost using nowadays for every hypertension patient, but definitely resistant hypertension, it has shown benefit in few patients. Even I advise that those of patients already on the AC inhibitors and ARBA can be shifted to the higher doses of sacubitril valsartan combination, considering heart failure definition is type A or type B. Patient those at the risk of developing hypertension, like diabetes, hypertension, obesity. If there is no contraindication, these patients should be put on the sacubitril valsartan combination to prevent the future heart failure.
And especially when the cost of ARNIs have gone significantly down, so it is in the affordable range. So 200 milligram BID should not be much problem when we are talking about something like a very resistant hypertension where the mortality will be significantly increased.
Last 1 month, my every patient gets this combination unless until contraindication is there for them.
No, but results are found to be very encouraging. Even personally, I am using it quite a bit. Not all, but quite a bit. But the results are better. Even their symptomatic stage improves. Not only the numerical blood pressure control, but the symptoms they come out later on for follow-up is much better.
Simple example I'll give you. One of the senior surgeons, 75-year-old, underwent a triple vessel stenting 2010. LV function is normal. Okay. He's already on the Cardes. Okay. And his BP is going up, and he came to me. BP is not much that time. I just shifted from Cardes to valsartan. He told his efficiency at 6 p.m. is comparatively better when he was on Cardes. Right. So this LV function is normal. I just shifted from Cardes to.
Right. One addition, if I may. There is one more actually off-label, but I would like to know from the experts. When there are CKD patients who are on maintenance hemodialysis, and most of these patients we have a cardiac element, cardiorenals, or getting the symptoms are getting worse and worse. So recently 2 or 3 patients, we actually added them on ARNI, and their symptoms like functional, all the class, quality of life, it was much, much better. With just 2 months, they are actually feeling better. So if we are ready to monitor their potassium, whether they are declining GFR on ARNI, even those who are on maintenance hemodialysis, ARNI can be added, provided you have to consult and talk it out with the nephrologist, because they will actually deteriorate because of cardiac failure rather than the deterioration of renal.
In these patients, probably the role of potassium binders, which are recently come into market like Patiomer, that will be helpful. And now coming to the last part of our discussion, the precipitants of heart failure. We know that anemia, NSAIDs, sleep apnea, all these are precipitants of both PEP as well as the REF. So any comments regarding avoidance or treatment or some kind of a precautions in this kind of categories?
Regarding anemia, in fact, there was a PRIDE HF study which was done at 5 sites in India. That was the largest available FCM, that is ferric carboxymaltose study, and our was one of the center of that 5. So we have studied at least more than 100 patients where we documented that there is iron deficiency, ferritin values are in a control. The results of ferric carboxymaltose are much better in terms of their symptomatic relief, in terms of their rehospitalization, and their quality of life questionnaire. They do much better. So these are very valuable additions which come. And two, many of the patients who have renal or gut intolerance, or simply they don't tolerate these iron supplements, this ferric carboxymaltose works very fantastic and it improves the NYHA class. So very important addition. Second thing is about NSAIDs. So I take a way out to educate them that not to take these medicines. Even a 1 or 2 pills can drop their GFR and complicate the issues, or fluid retention because of these NSAIDs, or simply a cardiac decompensation because of that NSAID. To the extent there might be a acute coronary syndrome because of NSAIDs.
So they can produce a plaque rupture as
Plaque rupture and all. So at each point, NSAIDs can be problematic to the heart failure patients, and there is strict no-no for these patients.
The monitoring iron levels, usually we do serum iron and all these things, but they are of not much value. It is the serum ferritin and T-sat saturation that should be monitored. And apart from that, the sleep apnea is a quite significant subject. Now, previously the person has to go stay in the hospital, enter the sleep laboratory and have sleep studies. Nowadays, the portable monitors, the people can go to their home and they can do the sleep monitoring with a reasonable cost. But in some of the patients, it can dramatically reverse, or they can significantly act to improve the quality of the life of that person. So sleep apnea also has to be looked for in these kind of patients.
Recently, I had one interesting patient. He was obese, middle age, 50 years. He was diagnosed to have a sleep apnea 3 years ago. He was not taking the CPAP therapy. Then he presented, he was having uncontrolled hypertension, presented with AFib and heart failure. So we just decongested him. We started CPAP therapy in hospital. His AFib got control. And after 2 months of follow-up, he has reduced significant weight, 8 kg of weight, BP is under control, he's in sinus rhythm, and he's regularly using CPAP. He's symptomatically much better with just beta blocker therapy.
Now, nowadays, there are a lot of treatments for sleep apnea. One of my friend is suffering from sleep apnea, and his brother is dentist in US. So he had brought some dental appliances where it will prevent the tongue fall. So this is one treatment. Secondly, surgical treatment. It is a uvuloplasty. In these patients, the crowding of the upper mouth cavity, which will be significantly improved by doing a surgical treatment. And thirdly, just asking the patient to lie down on a side, it will also significantly improve these kind of patients. So I thank you all for all the informative discussion, and probably it will help us also to improve our quality.
Can we take one part of discussion related to ARNI? How many people, or how many of your patients you have seen that after using ARNI, LV function is improved? And what is your observation? Use of ARNI and improvement in LV systolic function?
I mean, it's substantial. Where we have seen there significant number of population. Means I can say maybe 50 to 60% of the patient, I do see an improvement in LV ejection fraction. But even if I will say the EF doesn't change, but the diastolic parameters changes, their right ventricular systolic pressure changes, and that still brings out them the significant symptomatic relief. So even if the number has not changed, still the function or the improvement is significant.
Because we are quite busy in our practice, we are very reluctant to do every now and then echoes. But whenever there is an opportunity to echo, because some patient insists or we want to see that patient has significantly improved, there will be significant improvement in majority of the patients with beta blockers as well as with ARNIs.
So we had one interesting case, postpartum cardiomyopathy patient. She was taking all guideline directed medications for last 1 year. The problem was whenever ARNI dose was increased, she used to develop the hypotension. And nobody tried to increase the dose of ARNI, and his LV was 20% RV dysfunction. We admitted her, decongested properly, and we increased or escalated the dose to the 100 milligram BID in hospital. She had transient hypotension, but she tolerated the dose. Now after 3 months, it is a near normal LV function, which was like, to me, it was very surprising.
Miraculous kind of.
I want to add on this, sir, regarding the blood pressure. What I remember, I first started the ARNI, the blood pressure was 86 for that patient. and that patient is having EF of 15% and he survived for the more than 3 years and he died because of renal dysfunction and renal infection. Okay, so blood pressure is not a criteria. Only criteria may be a postural hypotension. You can
symptomatic hypotension.
And apart from that, the end organ perfusion, the meditation has to be good. The extremity should not be cold. The blood pressure up to 90. If somebody is having a blood pressure of 94, which is ambulatory, it is better with a higher dose of Arnis as compared to blood pressure of 100 and giving 50 milligram half a day, half BID. So probably
I think
blood pressure 90 should be a cause of concern. And in all these patients, we have to check the blood pressure on the other limb, because half of our patients will be having ischemic heart disease, some will be having subclavian atherosclerosis, and we reduce because and we know it after long time. One of our assistant checks on the other side, and we realize that it was
we had done the radial plus.
yes.
And second thing, most of the time we get call from the general practitioner. Sir, BP is 90. What to do?
No, I think BP is the only, it doesn't decide about the cardiac output. BP is one component of that cardiac output.
Unless it is a symptomatic hypotension, I don't reduce on Arnis. If he's perfusing well, if his brain is functioning well, kidneys is pouring out and he is happy.
Even of late we are seeing a lot of prescriptions with the inadequate dosages of Arni, 50, half or 50. And I personally feel that the response to the LV function improvement is dose dependent. And probably we have to try to escalate the doses.
Yes,
it is basically a question of non-compliance of physicians or non-compliance of patients. So either of these two has to be improved.
Question, sir. After starting Arni, if the patient's ejection fraction is improved absolutely to the normal, then what will be your take on continuing Arni, or what?
So that's what the guideline says, that if you are stopping it after 6 months, 50% of the patient, there will be reduction of ejection fraction. They will come back with a heart failure. And second time to treat them, I have seen for a lot of patients, to treat them subsequently, secondarily treating them, it becomes a very difficult matter.
They are not responding.
Not responding
what
to.
What may be the reason behind that? Because I have
Probably it has gone down the line, whatever the structural abnormalities, they have gone far forward and now they are irreversible. Previously, which was reversible mechanically or maybe biologically, some subcellular mechanisms which we are not understanding till now.
This looks little bit weird, because after improving to the absolutely normal LV function, because echo-wise also we can assess that, means scar and all could not be that much seen on those LVs. And suddenly after stopping 6 months down the line, they become 20-30% again dilated.
Just to add some point, actually we do only marker as a natriuretic peptides.
Yes.
Recently there is a lot of interest in ST2, which is a tumorigenesis suppression factor. It binds to the ligand of IL-33, which is an inflammatory marker, and once it is bound there, it will lead to significant reduction of hypertrophy and fibrosis. So whenever the soluble ST2 levels are increased, if they are more than 2 times, then the prognosis is significantly improved. It is not related to age, it is not related to LV function. But apart from that, if somebody is having more than double the ST2 level, the chances of sudden cardiac death will be increased by 5 times. So till now we are not understanding it fully. The problem with us is that it is not available in smaller cities like ours. It is available in metros, and we cannot do every now and then. It is very difficult to do. But these are subtle things which probably 10 years later, if we discuss the same subject on a same forum, we'll be having different opinions with change in scenario.
Other drugs, it doesn't happen, but only with Arni actually it happens most of the time.
Because we are not understanding the perfect mechanism where it is working, apart from whatever we have been put forward, that the neprilysin inhibition, the increase in vasodilatation. There might be some mechanisms which till now we are not understanding.
Actually, neprilysin inhibits so many of the substrates that it is very difficult to
don't know
elucidate.
each and every,
And
like
that's why
adrenocorticomedullin, which we are hearing it for the first time. There is apelin. So what these substances are, we don't know. What is its physiological function? We know that they are vasodilators, but what exactly subcellularly they are doing, what they are doing in the mitochondria, what they are doing to the myosin, we don't know.
the wonder is caused because of only sacubitril. Actually, valsartan was available for many years. The wonder is by neprilysin because of so many other pleiotropic effects. And that's
Second
why
thing,
the
I
change.
want all of your experience regarding to Hirsugat, because almost 100 patients I use, it has shown benefit in few population who are deteriorating on the all 4 pillars. But the result is not dramatic as Arni for me. And it is not like what Arni has made difference 5 years back. Hirsugat for me, I am using more than 100, but definitely some patient who are repeating admission, that is decreased. Okay, so what is your experience regarding the Hirsugat? Everybody just can add a point, few points.
I have started it on very few patients because it's a costly drug. The problem is what? We can start these kind of drugs in few patients. The problem is that the patient become non-compliant after few months. Like the cost, additive cost, which we were discussing just some time back, even though the cost have come down with the period of time, the cumulative cost of all medications, because 50% of our patients are ischemic heart disease, they are taking high dose statins. Apart from that, there are a lot of costly drugs, like all these, except for aldactone, the pyrrolizine and all these brands are very costly. Early, even though the cost has come down, the total cost for a single patient buck comes to more than 10,000. So for our majority of patients, maybe more than 80% of the patients, it's an affordable game to have kind of an additive treatment. I'm not saying that vericiguat is not having an advantage, but
yes,
it's the difficulty in
yeah.
continuing it for significant amount of time.
No, but the proportionate benefit what we get out of these are mortality reducing drugs. While vericiguat is a symptom improving drug and a reduction of hospitalization. So that's why even my personal experience is limited to maybe a double digit patients.
And regarding mortality benefit, I want to add something. We know that streptokinase was used for a long time, and we were, because we were in the learning phase, there was no trial for significant amount of time that tenecteplase or the previous RTPA was having a benefit as compared to streptokinase, unless a trial of 45,000 patients which were compared between streptokinase and TPA was tried. So unless that a magic number of 45,000, the previous trials were 20,000 and 25,000. So it is very hard to have a conclusion with a trial which is having a 5,000 patients, has been studied only for 10 months. The trial was given a trial duration of only 10 months. So how it will have a mortality benefit? So for that matter, the trials has to be bigger. It has to be conducted for at least few years, because even for these patients, 2 years time is also not significant. So to understand what is happening inside the body, how it is acting, we should have more data, but it is practically very difficult. That's why the drug companies are not doing it.
I think putting them on the first 4 pillars is very important, and optimizing it rather than trying to add fifth in a hurry. But it's an important and good addition.
Yeah. The second thing, that what happening in our population, we are not up titrating the doses, that we are lacking. Means most of them lacking, because most of the patient tolerate metoprolol 100 BD, almost Vimeda full dose, aldactone up to 50 milligram, and dapagliflozin. So up titrating the beta blocker, which we are lagging, I think most of the patient tolerates 100 BD of metoprolol.
They do tolerate. See, there is I will say a good 20-25% of the population who tolerates full dose of beta blockers. Full dose. You put 10 milligram or 200 milligram or carvedilol 25 BD. But yes, it's a 25-30% population. Lesser than that, like 15-20%, you give 25 and they are into hyper, like bradycardia and all. It all depends on their liver and metabolism. So hyper responders and hypo responders both are there.
It is basically a bell-shaped curve.
It's a bell-shaped
few
curve.
patients
So
will be tolerating all 4 drugs and full doses.
we should make all the
One
attempt to put
practical
them on
thing what I've noticed, whenever you are escalating the dosage of drug, patient get confused. He thinks that he is feeling better, and why doctor is increasing the dose?
And it is very difficult to explain to the patient.
That's what, down the line, who knows, there will be a guideline, start with a quadruple drugs at a low dose, and then gradually go selective on couple of drugs. That's
or maybe a polypill will come.
all drugs cannot be up titrated at the cost of the...
how we convince the patient.
Yes.
So when I tell them 200 is the dose. But for you and you, I want to start with low dose, we'll start with 25. We will increase. So he knows right from beginning that next time I have to increase. So it's how we tell them.
So
dose is 200.
Rather it is the art of the practice rather than the science of it. So thank you very much for the company people as well as to all my colleagues. And I think we can discuss during lunchtime.
Yes. Thank you. It
very
was a
much.
good discussion. Thank you all.
Thank you, doctors. Thank you for sharing your valuable expertise and sparing your valuable time with us. And the discussion happened very well. Mainly GMT as well as HFrEF, HFpEF, and many aspects of heart failure therapy has been discussed very much, and it will be very useful for many of the things which are in heart failure therapy. So thank you, doctor. With this note, I would like to conclude today's meeting on peer exchange form of heart failure. Thank you, sir. Thank you very much.